Hey, good afternoon to everybody. I am Emilio Herrera, Chief Cardiology Fellow at Universidad de Antioquia in Medellin, Colombia. Today, we feel very honored to have here with us Professor Wilfred Mullens and his lecture, How to Treat Congestion. He is a cardiologist, a heart failure and cardiac device specialist at the Hospital Ziekenhuis in Hank, Limburg, and professor at Hasselt University in Belgium. He is a fellow and board member at the European Heart Failure Association, and he's also the HFA 2023 Congress chairperson. He is also a peer reviewer for several cardiology journals, including JACC, ACC, ESC, and ESC Journal, amongst others. Invited speaker on a regular basis of ACC Congress and ESC Congress, and he's the principal investigator in several biomedical research projects and clinical trials. And he is also the author of more than 200 peer-reviewed publications and book chapters. So we're eager to learn from you a lot. We feel very honored to have you here with us today, Dr. Mullens. So please go ahead and welcome.
Well, thank you for the invitation, Hector, and good morning or good evening for everybody in Belgium. It's evening, I think for you it's still early morning.
It's like
afternoon. Okay, that's it. Okay. Yeah, I was fortunate to visit Colombia last year, somewhere in September. So you live in a beautiful country. It still has some negative reputation in Europe, but that's changing very rapidly for the better. So that's a good thing because
we hope to change for better.
Yeah, absolutely. And I think it is changing also the perception that people have. So thank you for the invitation. I'm going to guide you for how to treat congestion. I have some disclosures, and I think the largest one is that I'm a heart failure specialist, and sometimes I think I should have become a nephrologist. Like Hector said, we do a lot of research. It's of course not me who's doing all the research. I was fortunate to be blessed with a lot of very smart young people. These are the last 12 that we had, and all of these people did tremendous amount of work helping us to sort out how to deal with congestion and how to treat patients with heart failure better. I think we have to recognize that we do underappreciate the risk that our patients have when they have heart failure to die or to be hospitalized. The risk goes up to 20% at 2 years to die or to be hospitalized if you have ambulatory heart failure, and it goes up to 60% at 1 year if you have acute heart failure. So it's very important that we try to get rid of congestion in order to improve their outcomes. 20% is not nothing. That means that 1 out of 5 of the patients that you see in an ambulatory basis will either be dead or hospitalized 2 years later. We know from Greg von der Rohe already almost 3 decades ago that it's more important to reduce filling pressures on the left side than it is to improve cardiac output if you want to improve prognosis. The same is true for the right side. We, but also people in the Netherlands, have shown that if you have an elevated central venous pressure, that contributes not only to worsening renal function, but also to poor outcomes. So it's important to treat this elevated central venous pressure very aggressively. This was an animal experiment where we did a partial ligation of the vena cava inferior in rats. And as you could see already after a couple of weeks, there were irreversible changes to the glomeruli of these rats. This means that if you have a patient with heart failure and you let a central venous pressure be above 10 for 3 to 4 weeks, already there will be irreversible changes to the glomeruli. CKD is more important as a prognosticator than ejection fraction. So chronic kidney disease is the worst comorbidity that your heart failure patients can have. Normally you lose about 1 ml per GFR per year once you reach the age of 50. And this goes up to 5 ml if you have extreme heart failure, but if you have compensated heart failure, it goes up still to 2.5 ml per year. We have 2 drugs now that can lower down this decline in GFR, and that is sacubitril/valsartan and SGLT2 inhibition. So it's important that we try to give our patients those drugs that can lower down the decline in GFR. How can you evaluate congestion? I'm not going to go in detail. People always tell me that it's difficult. There are a lot of biomarkers around, of which I think the most important one currently is NT-proBNP. If you have a patient with dyspnea and you measure the NT-proBNP and that NT-proBNP is normal, then the dyspnea is not caused by heart failure. If you want to evaluate signs and clinical signs of congestion, you have to do a clinical exam, and you can combine it with a technical evaluation to actually evaluate the level of congestion. We put in the guidelines in HFA that we absolutely strongly recommend that you exclude signs of congestion before you discharge your patient home. This is a very important recommendation. You should never discharge a patient when that patient is still congested. You have to try to get rid of the congestion, of course, also in ambulatory patients, to improve outcomes. Now, if you think how does congestion actually arise, you may wonder, when do you have to go to the toilet most rapidly? If you drink water, or if you drink an isotonic solution, meaning water with sodium. Most people will probably say if you drink the sodium, but that's not correct. We know that if you drink 1 liter of water, then your osmolarity will change, which is not really tolerated by your body, because if your osmolarity changes, you have the risk of having edema of your brain. Therefore, if you only drink water, you have to go to the toilet really rapidly. But if you drink water with some sodium, that is very difficult to lose that, because that goes to extracellular volume regulation, which is mainly determined by the RAS system, which happens to react pretty slowly to volume changes. Another important thing to remember is that if you eat sodium, you cannot lose sodium in your gut. Every bit of the sodium that you eat will be absorbed in your gut. So it's very difficult to lose sodium, not only in the kidneys, but also in your gut. The reason for that is that we are walking upright and we need a high blood pressure. And having a high blood pressure means that you have to retain sodium, because sodium will determine your blood pressure. And if you would eat every day 1 bag of potato chips, you will have indeed an increased natriuresis, so you will pee out more sodium. However, you will not pee out everything. You will have a positive sodium balance as soon as you start eating these potato chips. That means that after 1 week, you will have more sodium in your body than what you would have today. So that's an interesting thought, because most of my physiologists, when I was in university, they taught me that the body is always in equilibrium. And if you would eat more sodium, you would pee it out. So that does not seem to be correct. We have sodium stores. And these are stores in your skin, in your bone, in your cartilage, where you can store sodium without water attraction. And that's an important concept. That means that you store that sodium there and you will take it out in case you would need it. And we know now that patients with heart failure cannot store that sodium well enough. Now let's think about the kidney again. How can you get rid of water and sodium? If you look at the kidney, a normal GFR of 100 mL per minute means that you're going to filter around 1 kilogram of sodium every day. Most of my colleagues think that if I have a GFR of 10 mL per minute, so only 10% of the GFR, that is the reason why patients have more sodium retention. That is, of course, incorrect, because if you have a GFR of 10 mL per minute, you still filter around 150 grams of sodium every day. If you eat 4 to 5 grams of sodium daily in Colombia, it would mean that even in patients who have significant CKD with a severely depressed GFR, they still filter enough sodium to get rid of the sodium that they have eaten. So the sodium filtration is not the problem. It's the reabsorption of everything which has been filtered. Now, these will be 4 difficult slides, but please stay with me. This is how a kidney looks like. You have an afferent arteriole, then you have capillaries in the glomerulus, where the filtration actually happens. Then you have an efferent arteriole, and then you have again capillaries that run next to the tubules. So the kidney is the only human organ which has 2 capillary networks in series running next to the tubules. And that's really important. I will go over figure 1, 2, 4, and 5. What happens at the glomerular level? At the glomerular level, the only thing the kidney wants is to have a GFR of 100 mL per minute. The kidney wants to maintain a high GFR in order to filter all the toxic substances, otherwise you will die. So the kidney will do everything it can to have a GFR of 100 mL per minute. If you have heart failure, you have a reduced renal blood flow because of a reduced cardiac output and because of an increased central venous pressure. That means that your filtration, your GFR, would drop. In order to prevent a drop in GFR, the kidney will respond to the drop in renal blood flow by squeezing on the efferent side and by giving vasodilatation on the afferent side. Therefore, your filtration fraction, which is the ratio of GFR divided by the renal blood flow, will increase. Why will it increase? Well, you will maintain GFR of 100 under the conditions of reduced renal blood flow, and therefore your filtration fraction will increase. If your filtration fraction increases, that means that you're going to filter more water compared to here in the face of what's actually going to the kidney. So that means that the blood leaving the glomerulus will have a different oncotic pressure, because the blood that leaves the glomerulus will run in the peritubular capillaries. And the oncotic pressure here will determine the amount of water and sodium uptake from within the tubules back to the blood. So if I filtered more water, there will be a higher oncotic pressure in the capillaries running next to the tubules. And this will promote more water and sodium uptake from within the tubules back to the blood. And this, dear colleagues, is the reason why heart failure patients have an increased sodium reabsorption in the proximal parts of the kidney. If you go a little bit more distal at the level of the macula densa, which is the last part of the loop of Henle, there you have an endocrine sensor. And this sensor senses the amount of chloride passing by. If I have heart failure and I've reabsorbed more chloride proximal, that means that there will be less chloride delivery to the macula densa. If the macula densa senses less chloride, it will release a hormone which is called renin. So less chloride means more renin. More renin means more vasoconstriction on the efferent arteriole, which will increase the filtration fraction more. So this is a vicious cycle. Increased filtration fraction will lead to less chloride at the macula densa level, which will increase the renin levels even more, therefore, again, promoting an increased filtration fraction. The therapy that most of us are giving to patients who are congested is loop diuretics. Loop diuretics block the chloride uptake at the macula densa level. So if you would infuse yourself with loop diuretics, you will have an increased renin level, because you fool the kidney. The kidney thinks there's not enough chloride, and therefore you'll have an increased renin level. In the distal parts of the kidney, there will be less sodium, less chloride passing by. You have a very high aldosterone level, you have a very high BMP, and therefore you will reabsorb every bit of water and sodium that will actually pass by there, and therefore your urinary output will be significantly reduced if you have heart failure. The same is true in the abdomen. Also in the abdomen, there is a system of congestion. We're getting more and more congestion. And I would strongly urge you in patients who have renal dysfunction and heart failure to measure the intra-abdominal pressure. You can easily do that through a Foley catheter. And if the pressure is really high, if it's above 10 millimeters of mercury, check for ascites. And if there is ascites, do a paracentesis to make sure that the intra-abdominal pressure drops. Because if you have a high intra-abdominal pressure, you have more chances that your renal function will deteriorate. Now, how can we treat this problem? If you look at the guidelines, they will say that we should give loop diuretics with a class 1 recommendation to all patients to treat signs of congestion. Now, if you look at the study that actually evaluates loop diuretics, it's the DOSE trial. DOSE compared 4 different treatment strategies with loop diuretics in acute heart failure: continuous versus bolus, low versus high dose. When you looked at their secondary endpoint of all-cause mortality and heart failure hospitalization, almost half of the patients was either dead or rehospitalized 2 months after they finished the trial, which is not a really good success. If you then look at the freedom from congestion, so meaning how many patients were dry after 3 days of consecutive therapy, only 15%. So that means that most of the patients included in those were actually discharged with still volume overload. There are many reasons why loop diuretic therapy is ineffective in patients with acute heart failure, and I already told you most of them. But if you normally would infuse yourself with 40 milligrams of furosemide, you should be peeing out about 3 liters of water and sodium, which is not what's happening in heart failure. The problem is that loop diuretics were distal. They were distal from the site where most sodium is reabsorbed, and therefore they're ineffective to treat the problem well. We've tried to overcome the poor utilization of loop diuretic therapy by writing this document a couple of years ago, and it might be interesting to have a look at it because it has a lot of very interesting and easy to adopt flowcharts. Let me just guide you through this. One of the flowcharts is to treat patients with congestion with double the amount of furosemide acutely when you see them in the emergency room. And once you've given that, you have to evaluate the effect of the loop diuretic therapy immediately thereafter. You look already after a couple of hours if your patient is responding well to the loop diuretic therapy. It's like the door to balloon time when you do a STEMI, when you place a stent, you have to look at the effect of the diuretic. And either you do that by measuring urinary output, which should be at least 100 cc's per hour, but easier is to measure the urinary sodium content, and that should be at least 50 mg per liter. If you don't reach that target, you have to double the amount of loop diuretics already after 6 hours. If you reach the target, you give the same amount of loop diuretic therapy every 12 hours. There are 4 prospective trials ongoing to investigate a natriuresis-guided approach, an approach what we call nowadays desalination. All of these trials will report later this year or earlier in 2024. There might be a new solution for furosemide, which is this subcutaneous administration of the drug. It's still very early on to say anything definite about it, but there are trials being conducted with a sub-Q infusion of furosemide. Now, many times you also see worsening renal function while you're treating a patient with heart failure. How to deal with that? So if I'm faced with a patient with congestion and I see worsening renal function, meaning my serum creatinine goes up or my GFR drops, the first thing to do is to assess the diuretic response. And if my diuretic response is good, meaning I pee out more than 100 cc's per hour and my urinary sodium content is more than 50 mg per liter, then I don't look at the worsening renal function. This is what we call nowadays pseudo worsening renal function, and you just continue your decongestive therapy. If I have, however, a poor diuretic response, I have to rule out hyperperfusion. Hyperperfusion shock needing inotropic agents is extremely rare in patients with acute heart failure. Most of the times there's no hyperperfusion, but you just have to increase the diuretic intensity, and you might consider the utilization of IV vasodilators. I strongly believe that vasodilators still have an important role in acute heart failure. This is a normal heart. In the x-axis, you see preload and afterload, and the y-axis, you see stroke volume. A normal heart is preload dependent. So if you increase preload, stroke volume goes up. If you give a vasodilator to a patient with a normal heart, so without heart failure, you see a drop in blood pressure because you decrease preload, therefore decreasing stroke volume. If you have, however, a failing HF-ref ventricle, these patients are not preload dependent, but they're afterload dependent. And if you then decrease afterload, you increase stroke volume. If you decrease preload, you put them at a better point in their Frank-Starling curve, therefore also increasing stroke volume. So vasodilators are extremely effective in failing HF-ref ventricles. Afterload for the ventricle is so much more than systemic vascular resistance. Afterload is the dilatation of the ventricle. The higher the pressure, the higher the radius, the smaller the wall thickness, the higher the wall tension. This is the law of Laplace. And the drug that can actually lower down this wall tension is a drug that can lower down the volume of the ventricle. And the most important drug that we use almost on a daily basis in that respect is nitroprusside. Nitroprusside is a very cheap agent, and you just titrate it up to a mean arterial pressure of around 60. If you do that, you always see an improvement in central hemodynamics if you would measure it. You don't need to put in a Swan-Ganz catheter, but if you have a patient with a failing HF-ref ventricle with a lot of volume overload, please give them nitroprusside instead of giving them dobutamine, and you will see a spectacular improvement in hemodynamics. What are the other diuretic agents you might consider outside of loop diuretics? It's, for example, thiazides. Thiazides work distal in the nephron. They work distal from loop diuretics, and they might help you to overcome the distal hypertrophy that you see with chronic utilization of high-dose loop diuretics. They are linked, however, if you give them chronically, to an increased mortality, and this increased mortality is secondary to hypokalemia. If you look at the chlorotic trial, this was the only prospective double-blind trial with thiazides recently published, you see that there are more than almost 50%, almost 1 out of 2 of the patients included in chlorotic had a significant hypokalemia. So this is not a safe drug to use in everybody. What about high-dose spironolactone? That has been tested in the Athena trial. Athena compared low versus high-dose spironolactone, and this high-dose spironolactone did not lead to more diuresis, and it did not lead to a more reduction in NT-proBNP. So spironolactone, loop diuretics, thiazides, they all work distal from the site where most sodium is reabsorbed. And that is why we focused our attention for the last decade to block sodium uptake in the proximal parts of the kidney. And the oldest drug that there is acetazolamide. It's a very cheap agent that my friends take when they come to visit Colombia and go to high altitudes to prevent high altitude sickness. But it's also diuretic. And if you give acetazolamide intravenously, 500 milligrams on top of loop diuretics, just as a bolus, so 500 milligrams of acetazolamide IV bolus, you see that you have a doubling of the amount of sodium excretion in the kidney. So it's an extremely effective diuretic agent if you combine it with loop diuretic therapy. And that was the reason why we did ADFOR. ADFOR was the largest trial in acute heart failure with diuretic therapy ever performed. We started the design of the trial in 2016 and we finished the trial late 2022. The trial was really pragmatic. It was an easy trial to do in your own, actually to adopt to in your own center. ADFOR compared twice the home dose of loop diuretics plus placebo versus twice the home dose of loop diuretics therapy plus once daily acetazolamide for 3 consecutive days. So pragmatic trial. Everybody with acute heart failure on loop diuretics with volume overloaded could be entered in the trial, comparing high-dose loop diuretic therapy plus placebo versus high-dose loop diuretic therapy plus once daily acetazolamide. Our primary endpoint was, is your patient dry after 3 days of consecutive diuretic therapy, which is a class 1 recommendation of the guidelines. What is dry in the trial? Dry was assessed by heart failure physicians in a double-blind manner. Dry meaning no edema on the legs, no pleural effusion, and no ascites. And if you had those 3, then we deemed you to be decongested, just like you were doing in your daily clinical practice. You look at edema, you look at pleural effusion, and you look at ascites to either give or not give diuretic therapy. When we looked at the baseline characteristics of the patients included in the trial, these were elderly people, like we all see in Europe. Our emergency rooms are flooding with heart failure patients who are old, 78 years, average ejection fraction 43%, NT-proBNP 6,000. They all had comorbidities, average GFR of 38, so sick, old, frail people. Exactly the pragmatic kind of trial that we wanted to do. These patients were all really congested. They all had a lot of edema on their legs, 60% had pleural effusion, and around 10% had ascites. When we compared ourselves with the other diuretics trials, which I just talked about, you could see the patients included in ADFOR were older, were more on MRAs, and had significantly higher NT-proBNPs than, for example, in the DOSE trial. So they were really congested, very sick patients. The primary endpoint of the trial was, is your patient dry after 3 consecutive days of the combination of high-dose loop diuretic therapy plus acetazolamide? In the placebo group, it was only high-dose loop diuretic therapy, it was 30%. In the acetazolamide group, it was 42%, so highly statistically significant by just adding 3 days of a very cheap, easy-to-use agent. The drug was equally effective amongst all pre-specified subgroups. Young, old, high, low ejection fraction, it did not matter. Everybody had a benefit of the administration of acetazolamide. I can hear you think, I don't use acetazolamide, I do something differently. And we allowed that to do. So after 3 days, physicians could do whatever they want to get the patients dry. And the physicians actually achieved 62% dry at the moment of discharge in the placebo group. However, in the acetazolamide group, it was almost 80%. So that means that the upfront use of acetazolamide is extremely important to reach decongestion at the moment of discharge. Number needed to treat of only 6, really low numbers. The reason why you should be using upfront acetazolamide is to prevent loop diuretic resistance from occurring. And if you don't do that, you see loop diuretic resistance occurring. This is clear by a more incremental benefit of adding acetazolamide on the decongestion score every day after each other. We also showed an impressive increase in natriuresis, and we showed a reduction in length of stay of more than 1 day with the use of acetazolamide. The drug was really safe. There was not an increase in any of the predefined safety endpoints. Renal dysfunction, hypokalemia, hypotension was not seen more frequently in the acetazolamide arm. The drug also has been used for more than 70 years. Now, you might think, I use SGLT2 inhibition, and of course you should do that. SGLT2 inhibition is a chronic drug that should be used in all heart failure patients indefinitely to improve their prognosis. Acetazolamide is a diuretic agent that should only be used temporarily to decongest patients better. Acetazolamide interferes with 60% of the sodium uptake in the proximal parts, while SGLT2 only interferes with 5% of the sodium uptake. And there are many studies now that actually show us that SGLT2s do not increase natriuresis, but only increase an osmotic diuresis by the excretion of glucose. So they're not a diuretic agent to increase sodium, they're a diuretic agent to increase glucose excretion. I was really proud last year at EAC to present this trial. It was published in the New England Journal of Medicine. And again, 6 of the authors are young heart failure specialists who all contributed tremendously to the success of this trial. Now, some interesting sub-analysis, for example, on ejection fraction, there was clear benefit of the drug no matter what the ejection fraction was. Clearly here, the error bars are formed more from each other because we don't have many patients with an ejection fraction of 80%, but there was a maintained benefit all over the ejection fraction. I already told you that acetazolamide prevents loop diuretic resistance from occurring, and these data, I'm not going to go in detail, will be published very soon in European Heart Journal, which will explain the reasoning why this drug is so effective to prevent loop diuretic resistance. Also, the drug helps to increase natriuresis, and natriuresis is really associated with an increased risk to have a better outcome. So we think it's time to take a paradigm shift with regard to diuretic therapy. It's time for DOR to combo diuretic time. DOR for a combination with acetazolamide and high-dose loop diuretic therapy. Will this have an impact on the guidelines? Well, the guidelines will only be written in 2026, but we feel as investigators that it's safe to say that acetazolamide on top of loop diuretics is recommended for patients with acute heart failure admitted with signs and symptoms of fluid overload who were previously treated with oral loop diuretics to improve the incidence of decongestion. And that might either be a 1 or a 2A depending on the guideline committee. So this is the way I treat congestion. In acute heart failure, I use a natriuresis-based loop diuretics dosing together with acetazolamide. So I base my loop diuretics dosing on the natriuresis, but I always add the acetazolamide once daily. Once my patient is dry, I'm in the vulnerable phase. I switch IV to oral loop diuretics. I only discharge patients when they're dry, and then add an SGLT2 inhibitor. In chronic heart failure, I use the lowest amount of loop diuretics possible. I continue the SGLT2 inhibitors, and I try to up-titrate the neurohormonal blockers based on the strong HF data. So my conclusions are CKD and congestion are intertwined, very prevalent and related to worse outcomes. Hemodynamics promote sodium retention. Ongoing congestion should be our target through proximal working agents. ADFOR is the first randomized controlled trial with a primary endpoint on relief of extravascular volume overload. Acetazolamide is not only safe, but also cheap, easy to use drug, which is really effective. It prevents loop diuretic resistance and it works via desalination, which is linked with improved outcomes. So bear in mind that this is a very important agent to be used in acute heart failure. In contrast, SGLT2 inhibitors should be used in all patients chronically to prevent not only heart failure, but also the progression of CKD. I'm going to stop here and I'm more than willing to respond to any question you might still have.
Dr. Mullens, thanks a lot for your excellent lecture. We can start now with the discussion session. Doctor Clara Saldarriaga, profe, ya tiene el micrófono activado.
So hi, Dr. Mullens. This is Clara Saldarriaga from Medellin, Colombia. So my question is about your definition of being dry in the ADFOR trial. Because sometimes we don't have, for example, the opportunity to do an ultrasound in every patient or to check for pulmonary congestion with some other things. So in practical terms, what did you recommend us to use as a definition of being dry?
Well, I think I use a definition that probably most clinicians actually are using, and that's the definition, which is I don't see edema on the legs, I don't see pleural effusion, and I don't see ascites. We didn't use an echocardiogram to rule out central hemodynamics congestion. We just needed some technical exam to show to the New England Journal of Medicine, basically, we really did a thorough job to make sure there was no bias or there was no different interpretation of clinical signs of volume overload. Because I give diuretic therapy for signs and symptoms of volume overload. And that's why I think an easy to do volume scoring by ruling out pleural effusion and ascites and edema is probably the right way to go. But we did not do an echocardiogram. We did not check for B lines. We only looked very rapidly with an echo, with an ultrasound to make sure there was no pleural effusion or ascites to do the trial.
Thank you. I'm also want to ask you if you think that our definition of being dry should include, for example, the changes in natriuretic peptides once the patient is admitted to the hospital and before the patient is going to leave the hospital.
I think there are many definitions of being dry, but you have to differentiate between why do we use diuretic therapy? Again, we use diuretic therapy to get rid of extravascular volume overload, and I don't use NT-proBNP to assess that. So we have many patients who have an elevated filling pressure, where you take away the volume, the pressure might still be a little bit too high, the BNP might still be high, but we're not going to give them more diuretic therapy. We're going to give them more neuromonal blockers, for example, ACE or ARNI or SGLT2. So this is a trial done for diuretic therapy. This is not a trial to treat everything with congestion. This is a trial to treat that showed that you can easily or easier get rid of volume overload if you add acetazolamide. Now, don't understand me wrong. There will still be patients when you give acetazolamide that will be wet when you give the drug. But those patients probably need more attention. And those patients probably need more intensive regimen of diuretic therapy or the addition of other agents.
So thank you. And my last question is about what do you think about the hypertonic saline protocols also for treat congestion?
If they show me, if you can show me a trial like we did in ADFOR that shows me that you get more volume out than you put in, I'm more than willing to believe it. But currently, we absolutely are lacking any prospective double-blind randomized data on hypertonic saline. And the data that we have is observational. And if you then would actually measure or look at the data and you would measure the amount of sodium that they administered and compare it with the amount of sodium that they got out, you see that it's most of the times a positive balance. So that means you give more sodium than you get out. So currently, I don't see any place for hypertonic saline in my clinical practice, But again, if you do a trial, or if somebody does a trial and shows me differently, I'm more than willing to reconsider.
Thanks a lot for your answers, Professor. I'm gonna try to summarize some of the cardiology fellows questions, and we have two questions. First one being similar to what Dr. Saldarriaga just asked. What do you think about some relatively new surrogate markers like VEXUS, venous excess ultrasound, and CA125 to pursue decongestion? And second one, we here in Colombia, as in many other countries, we do not have acetazolamide in intravenous presentation. So what do you think of the oral use, taking into account that in acute heart failure, we have got edema, so it could be an issue to take into account?
Yeah, important questions, and I don't think we have the answers to all the questions. I'm just going to give my own personal view on it. I think with the new biomarker, the CA, we use it for research reasons, but we don't use it clinically. And personally, at this moment, I wouldn't spend my money on it because money is scarce. Even in Belgium, we don't have unlimited resources. So for research areas, I think you can do it. The VEXUS, meaning so the fast ultrasound, that's really helpful. I think in my daily clinic, I use it every day in every patient that I see in ambulatory care because I have an echo machine at hand. So I use a lot of VEXUS to quickly evaluate a patient for signs of congestion. The oral acetazolamide, I know that in many countries IV is not available, but I think you should try to push to your healthcare authorities to get it. It's a cheap agent. There probably also might be a Colombian pharmaceutical company willing to make it because it's so cheap, it's off patent. Now, I know that you don't have it, and what we then suggested to give it orally. And we have some data, we know also in Spain, they have done a small observational trial where you give 250 milligrams orally for a couple of days. And it also seems to work, but I think that the response is less predictable, Hector, for the reason you're stating, that we don't know about the GI absorption. So IV, we give 500 milligrams once daily. Orally, we give 250 milligrams because that's the amount of, that's what's in the tablet.
Thanks. We have another question here. It says, if my patient has ISGL2, what would be the cutoff point for urinary sodium excretion?
If they are an SGLT2 inhibitor, chronically, it depends if they're acutely or chronically. So if you're chronic on an SGLT2 inhibitor, you will not see any influence on the sodium excretion. So there, the urinary sodium content should still be above 50 mg per liter if you use loop diuretics in acute heart failure. If you start an SGLT2 inhibitor acutely in a patient with acute heart failure, there it's less predictable because sometimes you still see some increase in urinary sodium. So there we don't have the answer. But I think in the future, most of the patients who are admitted with heart failure are recurrent admissions. So it's, let's say they're 80% in heart failure already, we know they have heart failure. So in the future, probably most patients will already be on an SGLT2 inhibitor. And then the cutoff for sodium will be exactly the same as what we wrote in the guidelines.
Thanks. Professor, what would be the ideal moment to withdraw diuretics? Loop diuretics, but pragmatic answer would be when the patient is dry, but what is your opinion?
Yeah, I mean, you know, let me just go back to my screen because I put one slide in there to what I think when you can stop loop diuretics. And this is the way we do it. Oh, wait, let me go back. So there's no clear guidance. So I think there are some conditions for myself for successful down titration. My patient should be on maximally tolerated medical therapy. My patient should be compliant. There should be no residual congestion clinically. And there I use again the VEXUS to make sure they have a normal VCI. And if they have a normal RV function without significant TR, it's mostly doable to stop the loop diuretic. But it's important, I think the echo there is important. the lower NT-proBNP is important, and the no residual congestion is important. So in those patients, we try to stop the loop diuretic. And I must say that in almost 80% of my chronic heart failure patients, we don't give loop diuretics anymore. Because once they're dry, we just stop it. But it's important, you know, I think most of our colleagues are not getting their patients dry enough. So if I see a patient who's really wet in the ambulatory care, you know, we just sometimes say, you know, just come in for 3 to 4 or 5 days, we decongest you, then you're at a better point, we can stop the loop diuretic, and the tolerability of then the medical therapy is also a lot better.
Okay, thanks a lot. Había visto a Andrés Barragán preguntando, pero ya no lo veo para habilitar el micrófono. Andrés, si quieres preguntar. And we have another question here, and it's about secure or safety margins in clinical trials like ADBOR and like chlorotic, about renal events. What could you tell us about that?
Yeah, so we looked at renal events with regards to dialysis. So we did not see an increase in dialysis in any of the groups. And we also looked at, but I don't recall the exact number. I think a doubling of serum creatinine or something in our own trial, and we didn't see any increase in that. No, but you have to bear in mind that, again, like I alluded to, if I would see an increase in serum creatinine during acute heart failure treatment, and my patient is responding well to the therapy, I don't care. That doesn't mean anything. It's only the patient who has a worsening renal function in the light of still having persistent congestion with a poor diuretic response that I'm start to worry. So just looking at renal function without looking at the clinical picture of the patient is not the right way to move forward. So you have to do the interpretation. So just reporting on an increase in serum creatinine is probably not the right way to report on it.
Most of the patients will go well.
Yeah.
Andrés, ya tienes el micrófono.
Thank you so much, Dr. Mullens, for your conference. And my question is about other strategies for the management of congestion is the use of albumin in patients with hypoalbuminemia and the furosemide both in combination with albumin.
The combination of furosemide with what?
With albumin.
Bicarbonate?
No, albumin.
Albumin. Okay. Yeah. Again, there we are lacking randomized trial data on that. We don't do that anymore. We only give albumin to patients who are really high, who really have hyperproteinemia. Otherwise, we stop doing it. I think we always think, you know, if you give albumin, you increase the plasma oncologic pressure, and then you will have more water extraction from the interstitium. But it's very difficult to prove that it's actually happening. So we rarely give albumin. We only do it when the albumin levels are extremely low, when they're cachectic or something. Otherwise, we don't do it anymore. But again, I'm not saying that it's wrong that you do it, but I'm just saying we don't have the data to do it. Now we have some data for another therapy that seems to work well, safely. So, but there probably are many ways to decongest the patient, but almost none of them have any scientific evidence. And now finally we have something with acetazolamide, which is an easy drug.
Thank you so much, Dr. Mullens.
Well, we don't have any more questions in the chat or here, so I think we can happily end the session. Thanks again, Dr. Mullens. We feel really honored to have you here today with us. We look forward to hear from you soon again. Thanks a lot.
Pleasure. Thank you. All the best to everybody. Bye-bye.
Buen día a todos.